Welcome to The Explainer. Today, we are getting into a major turning point in liver disease, the development of ascites. Look, for any medical trainee, getting a handle on why this happens and what to do about it is just fundamental, because this is the moment when everything, and I mean everything, changes for your patient. So let's just jump right in with a quote that really tells the whole story. When a patient with cirrhosis develops ascites, it isn't just a new symptom. Nope, it's the big event. It's the signal that their liver disease has officially tipped over from a stable, compensated state into decompensation. This is a critical fork in the road.
All right, let's paint a picture with a classic clinical scenario. You're in clinic, or maybe the ER, and you're seeing a patient with a known history of cirrhosis. They've come in because their belly has suddenly gotten bigger, more distended. This right here, this is the moment their journey with liver disease takes a sharp turn.
And you're going to see this a lot. Every single year, about 5 to 10% of patients who were doing okay, with stable, compensated cirrhosis will develop ascites. This shift is exactly what we mean by decompensation, and it has massive implications for their future.
But why? Why does all this fluid build up in the first place? If you really want to know how to manage it, you've got to understand the mechanics under the hood, and it all boils down to a fundamental pressure problem inside the body.
The absolute heart of the matter is portal hypertension. The liver is scarred and cirrhotic, right? So it resists blood flow. It's like a traffic jam. That causes pressure to back up in the portal vein, which is the main highway for blood coming from the gut. This crazy high pressure is the engine that drives pretty much everything bad that follows.
Okay, so this intense portal pressure kicks off a whole cascade of events, starting with something called splanchnic vasodilation. Basically, the blood vessels in the gut just massively expand. Now picture your circulatory system like a plumbing network. If you suddenly turn on a whole bunch of faucets wide open, what happens? The pressure in the whole system drops. The body gets tricked. It thinks it's bleeding out, even though the total amount of fluid is the same. It's a really dangerous deception.
So in response to what it thinks is low blood volume, the body does what it's programmed to do. It hits the panic button. It activates these powerful hormone systems that scream at the kidneys, hold on to every last drop of salt and water. But this is a tragically misguided response. All that extra fluid the kidneys are holding onto can't stay in the blood vessels because of the high portal pressure. So where does it go? It leaks out and collects in the abdomen as ascites.
And here's why all of this pathophysiology matters so much. Here's the bottom line. The 5-year survival rate for a patient with compensated cirrhosis, it's about 80%. Pretty good. But once ascites shows up on the scene, that number absolutely plummets to just 30%. This one event is a hugely powerful prognostic marker.
Okay, so now let's switch gears to diagnosis. When a patient shows up with new ascites, we have to be sure. We need to confirm it's coming from their cirrhosis and the portal hypertension and not something else.
And that's the key question, right? Yeah, cirrhosis is the most common cause, but you've got to think about other things like cancer or heart failure. Luckily for us, there's a simple test we can do on the acidic fluid itself that gives us an incredible, almost certain answer.
And here it is, the serum ascites albumin gradient, or as everyone calls it, the SAG. The calculation is just beautifully simple. You take the albumin level from their blood, and you subtract the albumin level from their acidic fluid. If that number, that gradient, is 1.1 or higher, you are 97% certain that the cause is portal hypertension. It is one of the most elegant and powerful diagnostic tools in all of hepatology.
So, once we've confirmed the diagnosis, our focus pivots to management. We have to get this flood under control to make the patient feel better and prevent other complications. And our approach starts with 2 key pillars.
For moderate, or what we call grade 2 ascites, the first-line treatment is a 1-2 punch. Cut back the salt in their diet and start diuretics. The goal for sodium is less than 2 grams a day. But diet by itself is almost never enough. The real workhorse here is a combination of diuretics, usually spironolactone to fight that hormonal drive to save sodium, plus a loop diuretic like furosemide to help push it out.
But what if the patient comes in with grade 3 or tense ascites? This is where their abdomen is rock hard, they're in pain, maybe even having trouble breathing. In that case, we don't just start with diuretics. The immediate first-line treatment is a large volume paracentesis, or LVP. We've got to physically remove that fluid to give them immediate relief.
Now, hold on. It's not just about pulling the fluid off. When you do a large volume paracentesis, we're talking over 5 liters, there is a critical rule you absolutely have to follow. You must give intravenous albumin back to the patient. Why? To prevent a really dangerous circulatory collapse. The dose is easy to remember. 6 to 8 grams of albumin for every single liter you take off. This step is non-negotiable for protecting the patient's kidneys and blood pressure.
But what happens for that 5 to 10% of patients whose ascites just doesn't care about the salt restriction or the maximum doses of diuretics? Well, this is when we step into the much tougher territory of refractory ascites.
So, refractory ascites is officially defined as fluid that you just can't get rid of, or that comes roaring back right after you drain it, even when the patient is on all the diuretics we can give them. This is another really bad sign. It tells us the disease is very advanced, and it carries a grim prognosis. We're talking about a 50% survival at just 6 months. At this point, our management strategy has to escalate. Serial LVPs, draining the fluid over and over, becomes the main way to control their volume. But that's just a band-aid. We then have to think about more definitive options, like a TIPS procedure to mechanically lower that portal pressure. And most importantly, we have to refer them for a liver transplant evaluation. A TIPS is a pretty cool procedure. It stands for transjugular intrahepatic portosystemic shunt. A stent is placed inside the liver to create a new pathway for blood, basically bypassing the scarred-up liver tissue and relieving that intense portal pressure. In the right patient, it works wonders, controlling ascites in about 80% of cases. But, and this is a big but, there's a trade-off. By shunting blood away from the liver's filtering function, a TIPS can cause or worsen hepatic encephalopathy or confusion. So you have to be incredibly careful about who you select for this procedure.
Okay, before we wrap this up, let's talk about the one complication that every single trainee and clinician has to be on high alert for in any patient with ascites. It is a true, life-threatening medical emergency.
And that complication is spontaneous bacterial peritonitis, or SBP. This is a nasty, life-threatening infection of the acidic fluid itself. What happens is bacteria from the gut manage to cross over and set up shop in that fluid. The diagnosis is made by doing a paracentesis, sending the fluid to the lab and finding an absolute neutrophil count of more than 250.
The management steps for SBP are non-negotiable. First, because it can be sneaky, you have to do a diagnostic tap on pretty much every single hospitalized patient with cirrhosis and ascites. If that cell count comes back high, you start IV antibiotics immediately. Don't wait. And just like with the big LVP, IV albumin is crucial here too. It's been proven to slash the risk of kidney failure and death in patients with SBP.
So, let's bring it all home. The single most important takeaway from this whole explainer is this. Ascites is never just fluid. Its development is a loud, clear, unambiguous signal that the patient's liver disease has taken a turn for the worse. And it should always make you think about and discuss a referral for liver transplantation, because that's the only real cure for end-stage liver disease.
We've spent all this time talking about the fluid, but as you probably gathered, this whole process puts a tremendous strain on the kidneys, and that often leads to the next feared complication, hepatorenal syndrome. But managing that is a deep dive for another day. Thanks for joining me.